And hi everyone, and welcome back to our second keynote speaker for today, which is delivering value, improving outcomes in a post-COVID world, with Dr. Sally Lewis, who's joining us from Wales at 6 a.m. in the morning. So we've managed to get the Americans out of bed at 10 p.m. and now Wales at 6 a.m. So very much, Sally. And introducing Sally today is Dr. Zoe Weiner, who we met earlier on the clinical panel. Thanks.
Good afternoon. I'm Dr. Zoe Weiner, Director of Clinical Governance and Medical Director at Bupa, Australia and New Zealand. It gives me great pleasure today to introduce the next session, Delivering Value, Improving Outcomes in a Post-COVID World, presented by my close friend and colleague, Dr. Sally Lewis. I can confidently say I have learned so much from Sally, Alan Brace and the team at NHS Wales about value-based healthcare and remain very grateful for their outstanding work, intellectual generosity and collaborative spirit in building a global value-based healthcare community. Dr. Lewis has frontline experience of primary care at its most challenging. She rebuilt a struggling GP practice into one of the most successful in South East Wales, giving insights into clinical leadership and business management requirements to serve a deserving local population with limited resources. A career in medical management led to her appointment to Assistant Medical Director for Value-Based Care in an Iron Bevan University Health Board in 2014. Her current interests include the utilisation of value-based principles to allocate resources in publicly funded systems, including the utilisation of patient outcome data and digital transformation. Dr. Lewis is now the National Clinical Lead for Value-Based and Prudent Healthcare in Wales and the Honorary Professor at Swansea School of Medicine. She's also leading cutting-edge thinking in patient-centred value-based healthcare, as well as what it means at a population level. I have no doubt you will enjoy her presentation. Over to you, Sally. Thank you.
Thank you, Zoe, and wow, what a welcome. It's a pleasure to be here virtually. I'd rather be there in person, of course, but James was saying earlier that this is the Australians' final revenge on us POMs for getting you up at midnight for so many calls. So now it's 6 a.m. here, and I'm raring to go with my cup of tea. So great to have you on board. So over the last year, we've all been navigating the COVID seas, haven't we? And seen some extraordinary things happen throughout the course of the pandemic. And value-based healthcare was important before the pandemic, but arguably now, as we move into uncharted waters of even tighter resources and lots of people who have suffered non-COVID harm from having difficulty accessing healthcare during the pandemic, we need to be attending to their outcomes as well. So we need to be thinking about how we use our resources really wisely to get the best outcomes for as many people as possible in the coming months and years. On a positive note, we've seen tremendous digital transformation acceleration during the pandemic, and that offers real opportunities for value-based healthcare, because as I'm sure you know, digital and data are very fundamental pillars of implementing value-based healthcare. So hopefully some real opportunities there. So quick recap, value-based healthcare is about getting the outcomes that matter to people and understanding the costs in the system for delivering those outcomes. We have to look at those costs of care and the outcomes across the whole pathway of care for patients. So that means we need to collaborate across the whole system. A hospital alone cannot deliver full value for patients, neither can primary care. We have to do it in partnership. And the outcomes that matter are the outcomes that we've typically not collected in the healthcare system. They are symptom burden that patients are living with, quality of care, pain, sleep, can I play with my grandchildren? These are the things that are important and that we need to understand if we're truly to deliver value to patients. And that means that value is not just about cost effectiveness in the health economic sense, although that's an important part of it as we start to understand the value of drugs and devices in the system. It's about how we configure our resources, whether that's financial, human, or technical, to deliver value for patients and understand what is the best configuration to deliver the outcomes that matter to them. And then in publicly funded systems, we're also interested, aren't we, in equity and population outcomes. So how do we allocate resources to different groups equitably and understand that whole picture that maximizes value for the whole population? And that's an approach to value that comes from my colleague, Professor Samir Gray in the UK. So I think, you know, many of us have come from a world where we think we're delivering value to patients through efficiency and productivity, driven by evidence-based medicine. So it's tempting to confuse activity with progress, actually, and to assume that all productivity, all activity produces the best outcomes for patients. But that's not necessarily so, and I hope I'm going to illustrate that to you today. I was chatting to another close colleague of mine just yesterday, Chris McCabe, a health economist in Canada, and he said to me quite a profound statement, I think, which is, if healthcare does not achieve the outcome desired by an individual, it follows that it is of no value whatsoever. Therefore, we can only understand value when we link outcomes to the specific goals and context of an individual. So I want you to hold that in your mind, because even when we are efficient, productive, and follow the evidence, we don't necessarily achieve value for the individual. So what does a whole pathway look like from a value perspective? Well, this is an example looking at value in heart failure, and you'll see that it covers the whole trajectory of care, from not just people living with heart failure, but for those who might be at risk of heart failure too, because obviously the highest value outcome in this context is not to get heart failure at all. And so whatever we do in treating heart failure, we also have to max out on trying to prevent it and addressing cardiovascular risk factors from a public health perspective, but also in primary care and looking at primary prevention, smoking cessation, and so on. And you'll notice that underneath that pathway that leads from prevention through to timely diagnosis, optimizing intervention, supportive treatment, and through to end-of-life care, there are a series of activities and interventions that need to happen at various stages of the pathway. So once you move on from prevention, what we want is really early diagnosis of heart failure and efficient processes to get patients optimized with their treatment as quickly as possible. And then after that, it's really about how we manage that chronic disease in partnership with the patient. Supported self-management is very important. They may or may not at some point require a device. And then given that it is a life-limiting illness, they will likely at some point need to flip into palliative care, anticipatory care planning, and thinking about their preferred place of care at end of life. Now, you'll notice that this is totally service blind, and that's deliberate because there's a tendency in the healthcare system, I think, to always do what we've always done. So we might say, well, that must happen in primary care, or that must happen in the hospital setting. And the challenge here, I think, is to see what patients need and then figure out on a blank sheet of paper what's the best configuration, what's the best way to address that need and deliver those interventions, and therefore what's the best way to fund those interventions across the whole system. So some of this is about standardizing processes and doing the basics really well, and some of it is much more about learning from patients what their priorities are and how we achieve their outcomes. So how do we use financial mechanisms to support both of those aims? And I want you to hold that thought, because we're going to come back to that later. So first of all, a little bit about patient-reported outcomes, because there's often confusion, I think, about exactly what these are and how they can be used. Now, patient-reported outcomes have typically been used in research settings or to assess cost-effectiveness of interventions. And they still are very important in that context, of course. But they are essentially a structured communication between a patient and their clinician that enables us to codify their symptoms, the severity of their symptoms, as well as their quality of life. So from that perspective, I really see an outcome as being not just a consequence of an intervention, but a milestone, an end point, or a consequence that matters to a person at some point along the trajectory of their disease. And of course, there'll be different ways that we use that data when we're looking at a chronic disease like heart failure, whether we're using them in cancer or in episodic care like joint replacement surgery or cataract surgery, for example. So how might we use them? Well, at an individual level, we might use them as a symptom tracker. So in heart failure, the Cancers questionnaire, really useful at understanding how breathless people are over a period of time, whether they've got ankle swelling, whether they've got fatigue, how their disease is affecting their sleep, and so on. So that's a really useful tool to open up conversations with patients, support shared decision making around more advanced interventions, and acting as triggers for key conversations. So for example, if you've got somebody with a life-limiting illness and you can start to see from their PROM that their trajectory of symptoms is inexorably worsening, you can use that as a trigger for anticipatory care planning. You'll know that's really important because we're not great at that, particularly in non-malignant progressive disease. And then at an aggregated level, we can look at PROMs, we can use it as a quality improvement tool through comparing with others. We can use it to support the identification of unmet need. And I was very interested to read the consultation you've got out at the moment, looking at risk adjustment for people having subacute care in hospitals. So we'll come back to that later, because I think PROMs has something to offer there too. We can use PROMs as a flexible approach to caseload. So through the pandemic, remote care has accelerated massively in the UK, and I'm sure that's true in Australia too. But remote care is quite tricky. You know, managing clinical risk remotely is more difficult, clearly, than face-to-face. So having structured tools that look at symptom burden helps us understand and manage that clinical risk and support that remote care. We can look at identifying unwarranted variation, of course, as well in the context of outcome measurement. And in terms of assessing the effectiveness of really expensive new treatments, I'm particularly thinking of perhaps cell and gene therapies or ultra-orphan drugs. We can start to generate real-world information and real-world evidence of the impact of these exciting but very costly treatments as we adopt them. So back to heart failure, which is going to be a theme through the rest of this talk. I want to talk a little bit about the typical trajectory of heart failure in an individual patient. So when someone is diagnosed, they are typically fairly symptomatic, and clearly at that point their physical functioning is reduced and their quality of life is lower. So the high value aim there, of course, is to identify that really quickly and get them optimized on treatment so that the slope to that plateau phase that you see on the graph there is really steep. And we do that really fast so that we return that individual back to as high a level of functioning as we possibly can. Once we've done that, people remain stable for a number of years perhaps, and then there reaches a point where they start to become less responsive to treatment, and become clinically unstable. And that's where we start to see hospital admissions for acute heart failure, people retaining fluid, and so on. And then as we move further along the trajectory, more treatments may or may not have been added. We start to see a really poor response to treatment, and we need to then think about moving into the palliative phase. Now, I mention this because often we don't, as I said earlier, identify very well when people are going into that phase of clinical instability and poor response to treatment. And our response to that then is reactive rather than proactive. And that often creates low value care for patients, because we're not addressing their needs. They have repeated hospital admissions, which could have been avoided, and so on. And then we're not really great at understanding people's preferences and needs in terms of flipping to the palliative phase. So in a high value situation, I would suggest to you that we could standardize the phases 1 and 2, because that's doing the basics well and repeatedly over time to get good outcomes. And I think you can incentivize that. Whereas in the second half of the pathway, where there's much more uncertainty about personal preferences and context, it's very difficult to incentivize good outcomes there, because it's a very individual thing, and we need to be investing in the time with patients to understand what is going to deliver the best outcome for them in their own context. So where do PROMs fit into that? Well, I hope you can see from that trajectory how useful a PROM might be as you track that person's progress and you track their symptoms that give us an indication of where they are on that heart failure curve. And the time points that we measure those are generally standardized, although you can do them more frequently. And what you see down in the left-hand box there is the recommended timeline for PROM collection in heart failure from ICHOM, the International Consortium for Healthcare Outcomes Measurement. So incredibly useful tool to embed in direct care. So, what does this mean for individual patients? So this is John. John was a bank manager, a raconteur, a lover of cricket, and a pretty mean spin bowler in his day. John had heart failure, but he also had, mild to moderate vascular dementia, and was becoming increasingly frail. And John had entered that clinically unstable phase on the curve, where he'd started to have repeated hospital admissions. And on one of those admissions up in Leeds in the north of England, it was suggested to him when he was admitted as an emergency that he should have an implantable device, which would shock his heart back into rhythm if he had cardiac arrest, and it would also act as a ventricular assist device too. Now, that poses an interesting question, doesn't it? Because from a heart point of view, evidence-based medicine, evidence-based pathway, that was the right thing to do if you were just looking at John's organ. But actually, John as a whole person was terrified of a slow decline into dementia and of losing his independence, and had already taken a decision that he did not want to be resuscitated if he had a cardiac arrest, and had filled in a form to say that. So it would have been really easy for John to have been given a device during that hospital admission without him actually even realizing that was not particularly in line with his wishes. Fortunately, a very wise professor of cardiology spoke to John's family during the admission and teased out what was really important to John and John's family in this context. And John, supported by his family, decided not to have the device. And 8 months later, John died suddenly of a cardiac arrhythmia. Now, I tell you this story because from an outcome perspective, from a cardiology outcome perspective, if you were looking at the raw data, that might look like a bad outcome. Well, why didn't we put a device in John, and why didn't he live another year or two from the perspective of his heart failure? But from John's perspective, that was the outcome he chose based on his overall circumstances. So it's an important lesson, I think, because when we are looking at standardized outcome measurement, it can be extremely useful. It can tell us lots of information and really support the delivery of healthcare. But we need to think about it as well in terms of the preferences and goals of the individual. Otherwise, we risk doing the wrong thing, even if it's evidence-based medicine. So I can tell you this story because John was my dad. So evidence-based medicine, has it succeeded? Evidence-based medicine was supposed to solve all of this, wasn't it? And it's taken us a huge distance, actually, in standardizing care, giving us guidelines and pathways. And over the last 20 years as a GP, I've seen a massive proliferation of guidelines and pathways. And randomized controlled trials, gold standard for giving us evidence. But of course, randomized controlled trials are done in quite idealized populations. So lots of people are excluded from those trials, who we then extrapolate the evidence to when we adopt the product from that trial. So evidence-based medicine, absolutely great, taken us miles, but actually it does have its limitations. And so I want to take us back to the original definition of evidence-based medicine from David Sackett. And the bit that commonly gets really forgotten about, I suppose, in modern healthcare is the bit in bold type here. So yes, evidence-based practice is about using the best evidence in making clinical decisions, of course, and informing those guidelines and pathways. But it shouldn't create a conveyor belt. It means integrating individual clinical expertise with the best available external clinical evidence from systematic research, but also the patient brings to the encounter his or her own personal preferences and unique concerns, expectations, and values. So when we think about that in the context of variation in healthcare, this is the difference, isn't it, between warranted and unwarranted variation. So what else drives activity in the system? So evidence-based guidelines drive activity in the system, but we also have preference-sensitive care and supply-sensitive care. So preference-sensitive care is driven by patient choices. And patient choices, where they are, preference-sensitive, so should I choose to have my implantable cardiac device or should I choose to have a knee replacement, are highly influenced by the availability of time with a clinician and information for the patient to support shared decision making that's really balanced and where we've reduced that clinical bias, because clinicians, we all have a clinical bias and tend to frame things a little bit with patients. So we need to take away some of that framing. With the aim of meeting patients' goals, because people will tend to choose less invasive medicine if they can still achieve the same outcome. I mean, why wouldn't you? We need to seek those optimum trade-offs between benefits and risks. And of course, when you're doing shared decision-making with patients and supporting them in making choices like that, there's got to be evidence-based alternatives around. So, I mean, if all you have is a hammer, everything looks like a nail. So if primary care can only refer to hospital and there are no community services, that's what they will do to try and help their patients. So being aware of how we meet patient needs in the highest value way possible is really important in preference sensitive care. And then supply sensitive. So this is care initiated or driven by the professional or system. So guideline driven care is one example of that, but also the perverse effects of targets sometimes drives care. And the more care we do, the more care we do. So if you refer somebody then something else will happen to them, and something else, and something else, and something else. And that is not necessarily of high value for the patient or the system, actually. And follow-up appointments in outpatients are a really good example of that. And throughout the pandemic, we've seen a real acceleration in clinical teams about how to have flexible access rather than that kind of old-fashioned sequential visits face-to-face to outpatients, which are of questionable value. So how do we use our resources really intelligently and flexibly to support best outcomes for patients? There's a real opportunity to redesign new models of care now. I think it's quite exciting. So as I said earlier, I was interested to read this consultation that you've got out at the moment, and I was really struck by the amount of data that you already capture in a structured way in Australia, and felt a little bit jealous, actually, because we don't have that because of the way we fund the system in Wales, of course. And it's a short hop, actually, from some of the data that you collect in order to risk adjust and assess complexity of your patients and their likely needs so that there's correct reimbursement for the hospital, to this approach to outcome measurement in older people, where you'd be looking at a lot of the same data points, but you'd also be interested in things that are important to patients, like the time they spend at home, carer burden, and the degree of autonomy and control they have of their care. So of course you wouldn't want to collect all of this data in the hospital setting, but I was really interested to see how you could augment the data set that you're proposing in the consultation with even more of an outcome focus, working with your community partners. And that way you'd be able to understand the need, but also how you might be able to address that need in a high value way across the whole system. A bit like this. So this is a slide that that was lent to me by my colleague, Dr. Alistair Roves, who has just co-authored the National Clinical Framework in Wales, using a value approach to a whole pathway for frail elderly people. Again, it's service blind, but you can see these are all the types of things that population might need across the course of their illness. And Alistair's gone one step further, actually, and sort of taken them back to childhood to make the point that, you know, what we do with kids affects people throughout their whole life course, even when they're old and frail. So I think what this slide really illustrates is the importance of collaboration and partnerships. So in addressing this from a hospital perspective, how do you work with primary care? How do you work with the charitable sector, care homes, and also your municipal authorities to support care? So I hope I've made the argument that it's so important that we change our mindsets and create a culture that's focused on value, that creates a common language centered around outcomes. And it's a really good way, I think, to bring the clinical and financial world together, whereas historically we may not have mixed as professionals. If we're going to solve some of the challenges in healthcare at the moment, then we have to do that together. Bringing financial management, clinicians, operational management, and crucially informatics together to support a much more data-driven approach to decision making that's focused around outcomes. And the total outcome data set for a patient, of course, includes the case mix variables, the demographics, the treatment variables, their clinical outcomes, and these three domains are typically found in clinical audit. And then we add the patient-reported outcomes on top of that, which, as I mentioned earlier, is in two parts. One is about generic quality of life, and the other is about condition-specific symptoms, as we discussed in heart failure. It also covers things like psychosocial aspects, including loneliness and the burden of care for people. Because as we move into an era of increasing subspecialization and the ologies, people are seeing lots and lots of different healthcare professionals, and it becomes a full-time job for them. So we need to understand what that holistic care looks like in multimorbidity as well. So how do we collect patient-reported outcomes? In the past, it's been very difficult, costly, in a research context, very labour-intensive. And clearly, if we're going to do this as part of routine care and at scale, that's not possible. So we need to basically enhance our communication and our digital communication to facilitate this endeavour. Which is one of the reasons why I'm excited about the acceleration of patient-facing technology over the last year, because that will really create a movement towards much better and more robust patient-generated data, not just prompts. Because once we've enhanced the digital communication with patients, it also enables a bunch of other tasks to be completed by the patient with their clinician, flexible messaging, looking at blood tests and things like that. And then it allows that large scale and semi-automated collection of patient-reported outcomes, which is what makes it sustainable and affordable. In embedding this in direct care, it's got to be a meaningful exercise for patients and for clinicians, not just a data collection exercise going into a black hole. And therefore, data visualization for patients and clinicians, really important, because patients want to see this. They really like to track their progress on an application. So data interoperability becomes really important, and that's why I commend you to have your informatics guys in the room early, so that you can align your digital strategy with your clinical strategy right from the off. And then not only does that support the data collection, as I said, but it starts to really embed technology-enabled new models of care that really work for patients and clinicians, and potentially enable us to use our resources more efficiently. So that might be around appointment management and flexible access to clinical advice, prom collection, enabling people to see and share aspects of their medical record, and then later on, when we get a bit fancy, management of chronic disease through wearable technology and the like. So how do we pay for value? Now, this is a thorny question, and I mentioned when we were talking about heart failure earlier on some of the perversities that can occur if you pay for outcomes. You can inadvertently incentivize the wrong thing. But in thinking about this, I wondered if it was in two parts. And I wondered whether we could incentivize excellence where optimizing standard processes applies to just about everybody. So in that first phase of heart failure, for example, where diagnosis and early and rapid optimization of treatment, it applies to everybody and is not sensitive to preference so much. And we can really drive that, I think, by reducing unwarranted variation, avoiding under-treatment, and really rewarding the outcomes that matter to people. I believe that can be incentivized. And then in the second half of the pathway, this is Elizabeth Teisberg, by the way. You probably recognise her as one of the architects of value-based healthcare with Michael Porter. And Elizabeth increasingly these days talks about the concept of capability, comfort and calm. So being able to do what I want to do, to be free of suffering, and to be free of anxiety about my health care and my circumstances. So when we are really thinking about capability, comfort and calm, this is where investing where personal preferences matter. So it's difficult to incentivize this because you can create overtreatment, as we said earlier. So we need to avoid the harms of overtreatment. And the way we do that is to invest in our culture, in time with patients, and in being able to give people the right information in the right context to make the best decisions for them. So my bid is for a two-part financing for value: incentivizing excellence and investing where personal preference matters. So how would that look for John? Well, you'd incentivize the first bit for him, and then you'd invest in the second bit for him. He was very fortunate. He had the outcome that mattered to him, and that was important to us as well. But I'm very mindful that that doesn't happen to everybody, and we get things wrong along the way, both in terms of slow diagnosis and slow optimization in the first part of the pathway due to unwarranted variation, and similarly overtreatment in the second part of the pathway where the context is wrong. So incentivizing the first part and investing in the second part, I think, is a way to go for this type of disease. And I think that maps across to other chronic disease and the frail elderly as well. For planned care, what would that look like? I think it's the other way around. So for planned care procedures like joint replacements and so on, you would have your preference sensitive decision making at the beginning of the pathway. So really making sure that you know, a joint replacement is the right thing for somebody, and then of course you incentivize the excellence around your joint replacement pathway. So one final consideration is equity. I'm very concerned with equity and about making sure that we deliver outcomes for the whole population, no matter who you are, no matter what your race, colour or creed, where you're born or how much money you've got. And of course, all of us live in very inequitable societies often, but value-based healthcare can really help us apply a data-driven approach to this, so that we can understand how we are getting inequitable outcomes at a population level and what we can do about that. So in Wales, we're experimenting with this in diabetes to gain the insights how to tackle that at a population level by bringing cost and outcome data together across the entire pathway, and in particular trying to understand, for example, variation in amputation rate. What we found was, for example, a really worrying pocket in a particular urban area where men with type 1 diabetes under the age of 50 had a particularly high amputation rate, totally catastrophic for them and very costly for the system. So by bringing the data together, we can start to understand what it is that they're not accessing. You know, why is that the care that we're delivering for everybody else not working for them, and how can we tackle that in a slightly different way? And very often that means tweaking things, and things that need actually a very small investment to create a really big gain, really high value, really big gain in outcomes, and reduction in costs later on. So a couple of final things. I think what we're really trying to do here is find this sweet spot in the middle between person-centered healthcare, so what matters to the individual, value-based healthcare, from a technical perspective, achieving the best outcomes with the available resources for individual conditions, tackling unwarranted variation and waste, and using quality improvement approaches towards excellence and incentivizing that excellence, but also to get the greatest quantum of health gained for the whole population, and tackling equity. And some of these bubbles are in tension with each other, as you'll recognize, I know. So we can't ever fully solve this in a perfect way, but I think we can try to move to the center as much as we possibly can using this methodology. And so to conclude, my three take-home messages are this. We do need to invest in digital and data, and think about how we understand our costs and outcomes, including PROMs, across the whole system, and really link that to the digital health agenda and take the opportunity that revolution is bringing to us right now. Can we incentivize excellence? So can we standardize appropriately to reduce unwarranted variation and improve outcomes and value for the healthcare system? But we also need to invest in the patient and their preference sensitive choices towards capability, comfort and calm. Thank you very much for listening. Really looking forward to the discussion.
Thanks very much, Sally. That was absolutely fantastic. Really insightful. We've got lots of questions coming through, and I'll just encourage people, if they've got questions for Sally. This is a fairly unique opportunity to really ask some questions with someone who's done a lot of the hard work on implementation. A lot of people talking about value-based healthcare and PROMs. It's not many people around the world who have actually implemented, so this is a fairly unique opportunity. I'll start with an easy question though. How's COVID changed the approach to value-based care in Wales? Or has it? Has there been a change?
Great question. I think in the early phase of the pandemic, everybody dropped everything, didn't they? And you know, we all turned our eyes towards COVID. I redeployed myself away from value-based healthcare completely for about 3 to 4 months. However, once we got to last summer and early autumn, we all became very worried about non-COVID harm, you know, so what was the impact of people staying away from healthcare, you know, not being able to access support for their other problems. Then we had the acceleration of digital technology. So we had a total switching off for 3 to 4 months, and then a massive and renewed interest in value-based healthcare as a way out of a way to address post-COVID recovery, I guess. So I can say now that I have never had more engagement than I have now from right across the board for value-based healthcare in Wales, whether we're talking about clinicians, patients, finance or informatics. Everybody gets it now.
Which a follow-on question then, and I know you've done a lot of work on this, is the connection between, I guess, using PROMs to connect clinicians and administrators and finance people. I know you've done a lot of work with the costing people in Wales. Yeah, so
I work really closely with the finance delivery unit and with Alan Brace, of course, the director of finance at NHS Wales. And they do a huge amount of work to understand the costs and are also, as finance professionals, incredibly interested in the outcomes. I think, and yeah, we work on the data. We've started to work on possible solutions for improving outcomes, as I mentioned in the presentation. But I think that the fundamental thing about it is how we've entered each other's worlds. And you know, I was just a clinician for a very long time, and probably was one of those people that banged the desk and said, "We need more resources," you know, and why can't I do this? And you're terrible, and you're stopping me doing that. But you know, we cannot afford to have an adversarial relationship between the clinical world and the financial world anymore, because we can't solve these issues by ourselves. So the fundamental thing for me in Wales has been that cultural shift, bringing the clinical and financial world together, and now that has expanded further, as I said, to the operational management and informatics world as well.
Yeah, excellent. Thank you. And we know in Australia that there's a close correlation between quality and cost, that when we have better quality, we actually have lower cost. Have you done any work on the relationship between outcomes and cost in Wales?
Yeah, so there is a relationship between quality and cost, of course, but quality doesn't always equate to value. Because you can have high quality care that is of intrinsically no value to the patient, if that makes sense. So that's where we start to see that's the difference between high quality, technically perfect procedures and processes, as opposed to bringing in the outcomes, and that will tell you whether it's truly valuable for the patient. And that's important, actually, because it naturally leads us to understand that high quality care doesn't actually always reduce costs, because you might be taking somebody down a pathway that they don't want to go, and therefore you've invested in healthcare that isn't of high value for that patient, if that makes sense. So high quality care delivers lower costs in some contexts, but not always, and that's why we need the outcomes as well to demonstrate value.
Great. So it's quite a long question, but it's got a lot of thumbs up, so I'm going to read it. How can we increase patient empowerment and involvement in their own clinical decision making? Obviously, the story you've shared about your father, which is such a powerful example, demonstrated that. But how can we encourage and, I guess, empower patients to be more active participants in their care?
Fantastic question. And there are so many answers to this. I'm going to pick two. So the first one, I think, is around giving people information in a way that really supports their understanding and their management of their own condition. So supported self-management doesn't happen by magic. It needs time, it needs clinical engagement, and it needs information given in the right way to patients. Which is why I'm so excited, actually, about the possibilities of digital sharing of information. That's really important, because people often don't, we make a lot of assumptions about what people know and don't know about their condition. When we first started collecting outcomes in Parkinson's disease in South East Wales about 5 years ago, we realised, as we were asking people about their symptoms using the Parkinson's disease PROM, that many people didn't actually realise that some of the symptoms that we were asking them about were related to their Parkinson's disease. Well, if you think about that, that's a major problem when you're consulting, because that person isn't ever going to mention that to you as a clinician if they don't know it's relevant. So really democratizing that information really starts to involve and empower people in a very meaningful way. So that's at an individual level. And then the second bit, I think, is that if we're doing that over time with our population of patients, we will start to accumulate data so that we can predict how somebody is likely to do if they make a particular choice. So it moves us away from telling people what a randomized trial says to saying, people like you, with your characteristics, who have made this decision are likely to have this outcome. How can we then support your decision making around whether you want to do that or not? So that makes it much more real for that person, I think, and about their context. So that those would be two ways.
Yeah, thank you. And then a question from Barb Vernon is, you've talked about asking what matters to you. It's really a follow-on question, I guess. How hard was that to achieve that sort of cultural change of asking that in Wales, and how did you drive that sort of commitment to do it? Because it's a fundamental change, isn't it?
It's a fundamental change, and it takes time. So the story is that we had an influential leader in Alan Brace, who was Director of Finance in the Aneurin Bevan University Health Board, and then later became Director of Finance of NHS Wales. Without Alan, none of this would have happened, because actually the power in the healthcare system probably resides more in financial management than it does in the clinical world. That's my perception. So if things are going to happen, it's very often finance that can really drive that cultural change. So having that really passionate and influential financial leader was critical.
So what,
and then
what
he
did
recruited.
What did he do to drive that? Because it's hard probably to imagine.
So the first thing he did was, he got some clinical first followers, of which I was one. So he started to, at a very small level, start to build a conversation between finance and clinicians, and it was small. And then the conversations grew and grew and grew and grew. So at the start of the programme, I mean, it was a year's worth of corridor conversations, bribery with cake and coffee, before we actually ever started anything like a work program. There was a lot that, it's a lot of conversations and explaining to people that your intentions are noble, and this isn't just about arbitrary cost cutting, from a clinical perspective, or it's not you're allaying concerns from finance about profligate spending by clinicians, and you start to understand each other's world. It takes time, and it builds over time.
So building trust, I think, is the key
Yes.
message there. Yeah,
very much so. Yeah.
So on tools, and I guess this is a really big issue for us in Australia, is how do you make sure that the tools that you use for collecting proms are appropriate to sort of diverse groups of patients, so called, and other sort of culturally diverse groups?
Yeah, that's a really fantastic question. So the fact is that prom tools, we have to go back to understand how they were validated, and so the prom tools that we are using at the moment are, I would say, better than no prom tool, but for sure, there's a lot of work that we need to do to evolve those tools, to make them simple and short, apart from anything else, but also culturally appropriate, and so that they mean the same thing to different people in different contexts. And really, really important piece of work. It's come up a lot in relation to another piece of work I've been doing around lower middle income countries as well. So my sense in Australia would be, wouldn't it be really interesting if we were able to develop some more research into culturally appropriate proms? It's very much needed.
Great, thank you very much. Well, I think that gets to the end of our list of questions, I think. So I'll give people one last chance. You've got about 3 seconds to get something up. Otherwise, I'm going to say thank you very much, Sally, for getting up so early and joining us. I can see the sun window out the back there. And we really appreciate your fantastic insights, and we hope one day soon we can have you here in person to continue the conversation. So thank you very much, and we'll talk to you again soon. So we're now going to move into the concurrent sessions. I think we've got a 5-minute break, so people can get up, stretch their legs, and grab a coffee, and head back to the timeline, and then choose amongst the concurrent sessions for the last session of the afternoon. We've got a concurrent on clinical engagement in ABF, the impact of COVID-19 on healthcare delivery. That's a combined session. And then pricing and funding, followed by safety and quality. And then there's 4 presentations under coding and documentation. For everyone's attendance this afternoon, and we'll talk to you all in the concurrent sessions in 5 minutes' time. Thank you.